What's up, everybody? Dr. Adam here with the PT Initiative, and I want to do something a little bit different today. So I know I post a lot about different exercises and kind of ways to improve shoulder pain, back pain, hip pain, those sorts of things, increase your mobility. But I wanted today to kind of go over some things a little bit more behind the scenes. So what's my thought process? What's my evaluation process? Those methods and screens that I use, and specifically when it comes to shoulder pain. So I want to go through kind of a few bullet points and just kind of give you a little bit of a look behind the scenes of what's going on when I work with my shoulder patients. So basically what I want to start out with is looking at kind of top to bottom. We're going to go starting with the subjective. So talking with the person, getting their injury history, those sorts of things is very, very important. It lays the foundation for where we'll go when we're developing goals, a little bit more specifics on where they've been, what they've tried, what they want to do going forward. So things like injury history, prior injuries with the shoulder, what they did to recover, how was rehab, was it successful, was it not successful, those sort of things matter. Looking at mechanism of injury. So was this an acute issue? Was there one specific event they can point to that after this event, the pain started, or was it more of a gradual onset, developed over weeks, months, years, that sort of thing? Definitely going to play a huge role. And pain beliefs. So how they feel about their shoulder. Do they feel like the shoulder's never going to get better? I've tried everything. It's kind of hopeless, or they have an optimistic outlook on it, that sort of thing. So definitely going to lay a foundation for where we're going to go in the evaluation once we get that information. So I post a couple of stories every now and then kind of showing you some of my movement assessments, especially ones I do with the shoulder. So some of these may look a little familiar and kind of give you a little thought process of what I'm thinking when I'm going through these screens. So looking at movement assessment. So we're going to start with what's called active versus passive range of motion. So I'm looking at, active range of motion is what the person can go through. So if we're talking overhead range of motion, I'm going to have them actively moving their arms overhead, whether it's internal, external rotation, they're going to be doing that actual motion themselves rather than me moving the arm or the shoulder. So looking at active range of motion. So I'm looking at things, for example, do they have a painful arc? So if they're coming up in this abduction motion, is it pain-free? Then it's painful through here, and then it gets pain-free again at the top. So that'd be what we call a painful arc, and it just kind of points us in a certain direction. So any of these tests and screens aren't just you get one check box and you automatically know what's going on, but it can kind of, a couple of these data points put together can help you get a better idea of where to go with the treatment. So the painful arc, an example is going to be maybe we're looking a little bit more towards rotator cuff or something strength related at the shoulder. So we'll follow up with strength tests, a couple of other different tests that we're going to do, but that points us in direction towards rotator cuff. And that's just one specific example. So we're going to look at things like fluidity of motion. So how fluid, so if I'm looking at the back of the person, looking at their shoulder blades move, how fluid is that motion? Did the shoulder blades move differently on side to side? Once they get towards the top, is there a lot more elevation, more so than upward rotation of the shoulder blade? So we're looking at kind of how fluid the motion is. We'll check that in different positions. Asymmetry side to side. So that's going to be a big thing I look at is side to side. Is there a difference in motion, and how does that correlate with their pain? So, just moving a little bit different left versus right doesn't necessarily mean you're going to have a painful shoulder, but if it correlates to a pain response or a pain input that they're telling me about, then it definitely matters and I want to address it. Another thing I want to look at is kind of talking about passive versus active range of motion is if their passive range of motion is greater than their active range of motion, then I'm going to look a little bit more towards stability and in-range strength. So, all these things and tests that we're doing, they need to have a correlation to part of your plan of care and what they really need to work on to get them the best results. So we're not just doing these tests to check a box or put something down in our notes, but it needs to correlate to something that we're going to have in that plan of care. So this is just an example. So if they actively go through external rotation, or we'll take flexion, overhead flexion, actively, they can get this far, but passively they can get a lot further back. We're going to look a little bit more towards stability. So the joint's able to get into that position, but when they actively do it, they're limited. So not necessarily going to need a lot of, passive mobility or stretching because the joint can actually get there, but we're going to look a little bit more towards stability, motor control, end range strength. So what's going on that's causing their actual musculature not to be able to optimally put them in that same position that I could passively get them into. So another good example is external rotation. So if I'm having somebody in standing, just do external rotation here, but when they're lying on their back and I'm moving the arm passively, they can come all the way back here. There's something going on muscular wise that's not allowing them to get in that position. And a big way I see that is especially in prone. So if they're lying on their back and I check it passively and they're able to get here, but prone, lying on their stomach and their arm's coming up this way and they can't really get that arm up very far, then there's definitely going to be a strength in range, strength specifically, or motor control issue that we need to work on. So yeah, that's going to be a couple different positions that we'll check. And so that's some ways to correlate active versus passive range of motion, which is a really big thing to take into consideration. Moving on to treatment approach. So, okay, we've gone through this full assessment. There's obviously a lot more to it than that, but those are a few kind of nuanced things that I wanted to highlight. So treatment approach. The big thing I want to do is identify limiting factors. So this is going to be important for choosing the right interventions for this person in front of you. So if their limiting factor is not mobility and giving them a lot of stretches, you're not really going to get very far, because that's not what's keeping them from getting in positions they need to get into and doing what they want to do. So if the limiting factor is stability, pretty much primarily 98% stability, and you're giving them 98% worth of mobility work, then there's a disconnect there and you're not going to get the results you want. So, if mobility is the issue, so passive range of motion is limited as much as active range of motion, they're just not able to get there, even passively can't get into these positions. Manotherapy, self-mobilizations, all these different, that's kind of what all these different passive, different techniques. Self-mobilization is a little bit more of an active, but it's still kind of an input to change muscle length is what we're trying to do. So that's what we're going to get from mobility. So active mobility, passive mobility, whatever you choose and see fit based on the person in front of you, that's what we're going to use for that. Stability, we're looking at things like positional strength, scapular stability, rotator cuff stability. So again, if this person has the mobility, their joints can get into those positions that we need them to, but this actively with using their own muscles, they can't achieve that position. We're going to work on things for stability. So I use positional strength. So with the shoulder, this is really important. So, a lot of people can bench press a lot of weight or overhead press a lot of weight, but you put their arm in certain positions where certain smaller stabilizers have to engage, or we kind of put them in the position we want to for optimal movement overhead, but then they don't have that strength there. You realize that strength is very positional. And so, if they're a swimmer and they need to be able to get into that full overhead position, or they're overhead athlete, weightlifter, they need to be able to get in that overhead position. They need to have strength in that position, not just mobility, not just the ability to get into it, but they need to have strength in that position. So, and you can kind of get some issues with that. So if you've always had pain at a certain point overhead, your body's naturally going to try to avoid that certain position, and you might have a weakness in that position. So building up that strength in that position. And that's going to include things like scapular stability, rotator cuff stability, that sort of thing. But it's all going to depend on what that person presents with and what their goals are functionally. And then another thing is mixed. You can have certain mobility restrictions along the shoulder, whether it's pec or lat, but also they do need stability in that as well. So that's another thing too. Once you open up that mobility, you need to reinforce with stability. So if you just open up the joint joint range of motion, give them that mobility, but don't provide any stability to it, the body's going to tend to revert back to it because it doesn't have any frame of reference of how to stabilize in that new joint range of motion. So you do need to follow it up with that joint stability. So that's going to be kind of your mixed approach. So really finding what's the primary limiting factor. So is it mobility? Is it stability? You need to address that first, but there's going to be some components of both. Looking at coming up with exercises. So, I post all these exercises on my Instagram page. Here's some things that I consider before, I've got hundreds of shoulder exercises on my page and my programs, but which ones do I pick for each individual people? So here's some things I consider. So I'm gonna look at what is their pain-free range of motion. So if they're painful at 110 degrees abduction, 120 degrees of flexion, I'm not gonna give them something that puts them strictly into overhead position. So we're gonna start with below their pain-free range of motion. How can we maximize that strength in that pain-free range of motion? optimize those shoulder mechanics, strength, muscle engagement, those sorts of things in a pain-free range is where we're going to start. And then as that strength and mobility improves, we're going to start to gradually get up into where they can, those positions that they need to without pain. So forcing someone into a painful range of motion is typically not the best approach. So we're going to optimize our movement mechanics inside that pain-free range. Next is open versus closed chain. So I've talked about this a fair amount. Open chain is going to be the arms moving freely on the shoulder, and then closed chain is going to be the arm is fixed and the shoulder is moving on a fixed arm. So something like an open chain is going to be like a dumbbell press. Closed chain would be a push-up or a serratus press. So these things are going to matter. Different issues. I talk about this a lot in my shoulder blueprint program. I've got a bunch of videos that I talk about kind of when to use closed versus open chain and different pathologies that respond better to each. So if you want to know a little bit more about that, check out the shoulder program. Complexity of movement. So this comes down to if you give too many variables, so many different stabilizers or muscles are having to work at one time, you can kind of overload the system and you get almost a poor return on all of it, versus if you simplify the movement down to a more isolated exercise. So if there's one limiting factor, one muscle along there, it's kind of a limiting factor, you need to bring the movement down so that there's not so many variables so you can get the best out of that exercise. So, different exercises. So even something like if someone's having a really tough time engaging their serratus anterior, having them do an elevated single arm serratus press, that might be a little bit advanced because that's going to require core stability, a lot of stability around the shoulder. Maybe they need a more regressed where there's not as many components at play at one time. So something to consider there, and that's going to be different based on each person. And then something you need to ask for every exercise, this goes for rehab professionals, fitness professionals, anything. Before telling someone to do a certain exercise, you need to know what your objective is. So there's no good or bad exercises. There's just exercises given to a certain person based on how they present and what the objective of it is. So, I need to know basically when it comes all the way full circle back to this objective. So what are the goals for this person? What do they want to be able to do? And my exercises need to fit where they are functionally now, what they need to improve on, and then it needs to have a translation to their goals and what they want to be able to do ultimately. So don't just give exercises just to give exercises. You want to give exercises based on, you can have a clear objective with what you want to accomplish with that exercise and where to build from there based on that person and their goals. So anyway, those are all some things that I think about when I'm working with someone with shoulder pain. I'm coming up with a plan of care. Hopefully that was helpful. If you've got questions about it, let me know, and I'll try and do my best I can to kind of walk you through a little bit more of that approach. Thanks for watching.